Is there a message of necessity at the desk? There is a message of necessity at the desk. Move to accept the message of necessity. The message is accepted.
Welcome to another episode of Messages of Necessity, a regular podcast of the Empire Center for Public Policy. I am Cam Macdonald, General Counsel for the Empire Center, and I am here today with Empire Center's Senior Fellow for Health Policy, Bill Hammond. How are you today, Bill?
I'm good.
Good.
Happy to be here.
So we're here today because you had something of a scoop last week on the something called an MCO tax, where you reported out some numbers that weren't expected. Can we just start right from the beginning? What on earth what is this MCO tax that you were writing about?
So MCO is short for managed care organization. It's another word for health plan in this context. And this grows out of a tradition in the Medicaid world that is based on the fact that the way Medicaid is financed. From the beginning, the federal government has split the cost of Medicaid with the states. So the states would they would design a Medicaid program in keeping with federal law. That it would cost, say it costs $1 billion. The states would put up a fraction of that, up to half of it, and the federal government would match the other half. The matching rate varies from state to state. In New York, it happens to be right around 50%. So states figured out very early on, with this matching system, they could kind of game it. And the way they would do that is that they would impose a tax on the Medicaid system, on the hospitals that work with Medicaid, or in this case, on the managed care organizations that work with Medicaid. And if you tax Medicaid, the federal government pays half of that tax, the state pays half of that tax, but the state's half is a wash. It's getting that back in the form of revenue. The federal half is free money, at least from the state's point of view. And states figured this out very early on. They started taxing their own healthcare systems. And in some cases, they would directly reimburse the hospitals that they were taxing. And it was just a scheme for extracting money out of the federal government. And they didn't even have to spend it on healthcare. They could use it to balance their budget. And so that's a pretty obvious abuse of the Medicaid law. The federal government, recognizing that this was an abuse, they decided to set kind of parameters around these taxes. They didn't ban them completely because it was kind of tricky. How do you dictate where the states get their revenue to pay for Medicaid? But what they did say is, if you're going to tax the healthcare system, it needs to be broad-based, uniform, and redistributive. Broad-based meaning you can't just tax a single hospital. You need to tax all hospitals. Uniform meaning the tax rate has to be the same for all the various taxpayers. And redistributive meaning it needs to generally benefit the Medicaid population. That part of it, I have to admit, is I don't fully understand what they mean by redistributive. But the key thing here is that they established this statistical test to determine if a state proposes a tax, they run the statistical test to determine, is it redistributive? So all of this leads up to a couple of years ago, the state of California, which had one of these provider taxes, an MCO tax, and somebody figured out that if you designed your MCO tax in just the right way, and you excluded certain health plans and you covered certain health plans, and you had this very elaborate system of high rates for Medicaid and low rates for commercial insurance, you could generate just billions and billions of dollars of federal aid and still pass that statistical test. And CMS, to its chagrin, said, "Okay, you've passed our statistical test. We feel obliged to approve your plan, but be forewarned, we're going to change these rules so that you can't do this again after 2026." So California gets something like $19 billion during the period that this tax will be in effect, which you can use, again, for any purpose it wants. It's using some of it for healthcare and most of it for budget balancing. And New York saw what was going on in California and like, ooh, we won in on that deal. Even though it's a short-term thing, even though CMS is saying it's going to change the rules in 2026, New York is like, well, so long as the current rules are in place, we should do what California did. It's complicated enough that when the legislature approved this, they said, Health Commissioner, you figure it out. You and your staff and the budget division, you get together with CMS and you figure out how you can engineer one of these taxes the way California did to get maximum federal revenue at a minimum cost to the state. And I guess
so I read in your piece that they were expecting, compared to California, they were expecting, I guess, a modest amount, right, of like $4 billion. Do you have any idea where that number came from, that $4 billion estimate?
So when this was floated by the legislature during the budget negotiations in the spring, they said, we expect that we can realize a net benefit of $4 billion from a tax like this. And they kind of penciled that into the financial plan. In the final budget, the governor said, okay, we'll do this, but let's not count on any of that revenue right away because we don't know whether we're going to get it and we don't know how much it's going to be. So it's not technically, according to, at least to the budget director, it's not built into any of their financial plan for this fiscal year. $4 billion would have been a pretty aggressive amount because that's just a little bit less than what, what California is expecting. And California is almost twice as big as New York. So $4 billion is a pretty aggressive target. At any rate, a few weeks ago, it came to light that the state had submitted its application to CMS. It's formally requested permission, what's called a waiver, to go ahead with this tax, but they hadn't made it public. And so I submitted a FOIL request, a Freedom of Information Law request. And last week, I obtained a copy of what they sent to CMS, which shows, the structure of the tax, the rates it's going to charge, and how much revenue they expect to get. And the net revenue, remember, you're taxing the system at twice the rate you want to get back in revenue because the state's putting up half, the feds are putting up half, the state's half is kind of canceled out, and the federal share is your net benefit. So they're anticipating $1.8 billion, more or less, in net revenue, which is quite a bit less than the $4 billion that the legislature initially targeted. Exactly what the state's thinking was, why they didn't go for more money, why it came out to $1.8 billion, they have not said. And I'm anticipating that there'll be some level of disappointment in the legislature, that they'll think that the governor didn't go for enough money. And also that the interest groups who are looking forward to spending this money are going to be disappointed. But the thing is, the way they did this, the legislature literally delegated the power to the health commissioner. You figure it out. So, they kind of made their bed. They have to sleep in it. They gave the health commissioner the authority. The health commissioner and effectively the governor exercised their authority, and they came in with, 1.8 billion is the number.
So you mentioned earlier kind of that this tax needed to be broad-based and somewhat evenly distributed. So I was a little bit struck by the differences in the tax rates in this proposed MCO tax, in that people in the commercial plan, it's kind of a 5-to-7 ratio of people in the commercial plan, or members in the commercial plan, versus people under Medicaid in New York.
I think the ratio is higher than that. The tax on Medicaid plans can be up to $1,500 per member per year.
Yeah, that's what I'm saying. So let me clarify. In the commercial Medicaid plan, there isn't a huge difference in the membership months, but the rates per member per month, there's a significant difference, where it's between $1.50 and $2 per member per month for commercial. I guess the average person in a business, employed with an employer that provides their health care, compared to the essential plan, and then Medicaid, which is $25 to $126 per member per month. So just a massive difference between the two. What can explain that? Is that somehow in some black box of the statistical model of CMS?
If you want to maximize the benefit to the state, you want to primarily tax Medicaid and not the commercial part of your healthcare system. The federal rules ostensibly try to prevent you from weighting it so heavily to Medicaid, but the statistical test has this weak spot in it somehow. I mean, again, it's kind of complicated to understand, but the statistical test has a weak spot, so that if you engineer your rates just right, and you engineer it has tiers, small plans pay one rate, larger plans pay a second rate, and really large plans pay a third rate. It's kind of like the income tax with brackets. And if you structure those tiers just right, and you structure the rates just right, you can make it past the statistical test. Now, I should say, CMS hasn't signed off on this. There must have been some back and forth with the federal officials who make this decision. I'm expecting them to approve it, but for now, it's just a proposal, and we'll see. But like I say, the goal is to weight it as heavily as you can toward Medicaid, because that's where you're going to generate the federal match. However, you can't completely, ignore and omit and exempt the commercial plans. In the context of this tax, the amount that's being charged to commercial plans is pretty small. Like you say, it's $1.50 or $2 per member per month, which works out to like $20 a year, something like that, $24 a year. We pay thousands of dollars for health insurance. Maybe we won't notice that $24 or $30 a year. However, that's completely unreimbursed. Like when you tax the Medicaid plans, they're going to get their money back. The Medicaid plans don't actually pay the tax. Medicaid pays the tax. But the part of this tax that's on commercial insurance, which is it's going to bring in something like $75 million a year, that's completely reimbursed. That's completely coming out of the pockets of employers and consumers. And they're doing that not because they think employers and consumers, should be punished for buying health insurance. But because they're so anxious to get that federal aid, that bonanza of federal aid in their mind. I mean, this is a danger for consumers going forward, because we now have $1.8 billion in revenue that they've agreed in advance they're going to spend on healthcare. So that's another $1.8 billion that's going to get baked into Medicaid spending. It's probably going to take the form of increased rates for hospitals and nursing homes and other providers. Once those rates are increased, it's very difficult to bring them back down politically and logistically. It's hard to bring them down. So you're going to raise the rates based on this 1.8 billion. But CMS, the federal government, has warned that they're not going to let you do this forever. So when 2027 rolls around, the rules are going to change, and CMS might say, okay, you can't have this cockamamie tax anymore. If you're going to have a tax at all, it needs to be uniform. And that would mean suddenly the Medicaid plans and the commercial plans have to pay the same rate, which means a much higher tax than what's proposed now, a much higher tax on commercial plans. Now, the lawmakers would face a choice. We can increase the tax on commercial plans, or we can cut $1.8 billion out of Medicaid. It's hard to know in advance what they're going to do. I just know that they're very reluctant to cut any money out of Medicaid, especially a number that large.
And I'm assuming that this CMS, this Medicaid loophole that is causing this cash grab from the federal government is more likely than not to get closed up, because it's one thing that California figured this out. It's another thing when all the other states in the union start deciding that wait a minute, this is there, correct?
I mean, I guess you would like to think that CMS, like, this is really, when you really get down to the bottom of it, this is states taxing the federal government, which means a state taxing the federal taxpayers who live all over the country. And states should not be able to do that. It's not good for our public life. It's not good for our economy. It's not good for our federal finances, which are already kind of a mess. They have massive deficits. So you would like to think that CMS would say, no, right? And they would shut it down. However, the more states who get into this, that means the more political support you have for this continuing. And the more, like, the hospital groups in California and hospital groups in New York and the hospital groups in the other states that do this are going to want this boondoggle to continue. However bad it is for the federal government, they're going to want it to continue. And the people in Washington are driven by political motives like anywhere else. So, I mean, like I say, you would like to think they would shut it down, but who knows? I think it depends heavily on who gets elected president. I think a Trump administration would be much more likely to draw a hard line on this stuff. You might also expect a Harris administration to do the same thing, but the odds would shift, I think, if between those two options.
So I guess to sum it up, what we have here is we have this opportunity for the state of New York to tax the federal government to the tune of $4 billion or so that they thought. But the legislature had this goal, but left it up to the Department of Health, that somewhere in the mix of things with the feds, CMS, resulted in a much lower amount of expected tax, which will net something closer to $1.8 billion that may or may not be there in the future. And we still might all be left holding the bag if that money does come in and then goes away, because moving that glacier that is the spending side of the budget is going to be very difficult.
Now, I guess to maybe put a more optimistic spin on this, the way the legislature structured this tax, they said the revenue should go into, I think they call it the Healthcare Stabilization Fund, right? They come up with some name. So it's going into a fund to be determined how they're going to spend it. If you look at this as a short-term, basically one shot, right? You're going to collect it in 25, you're going to collect it in 26, and who knows what happens after that. So you can have 2 years worth of revenue. You could look for one-time expenses to use that for. So for example, you could use it if there's a hospital that needs to downsize and merge, you could use it to finance that process. That's a one-time event. And that, if the governor steps in and says, listen, we need to be responsible with this money, we can't use it for rate increases because it's going away, that would be a better outcome. And you might also imagine that was part of her thinking in going for a relatively modest amount of federal revenue with this tax, is that it will, whatever mischief it causes for the Medicaid budget will be that much smaller. If finding $1.8 billion in savings would be a lot harder, or would be a lot easier than finding $4 billion in savings. But New York, part of the background that we haven't talked about is that New York has the most expensive Medicaid system on a per capita basis in the country. It is already, I would argue, massively overfunded. It has, there's too many people enrolled, and there's too much money being pumped through the system. A lot of it is not going to patient care. A lot of it is just going to subsidize hospitals and nursing homes. And the idea that we would, just the constant pressure in Albany is to find more money for healthcare wherever they can. And so this temptation was just too much for them to resist.
Well, on that note, I guess we will adopt I'm going to adopt your optimistic position that even despite all this desire to bring money into the health system, that there's going to be some spending discipline around this $1.8 billion in each year. And
Don't bet the farm on that.
Well, I wasn't going to. I was just trying to be optimistic as we head into the dark winter. So with that said, this has been another episode of Messages of Necessity. We thank you for joining us. Please leave us a favorable review and recommend us to your friends. And with that, we will be with you next time.
For more news and analysis, visit our website and sign up for email updates at empirecenter.org. Follow us on Twitter, Facebook, and LinkedIn @Empire Center.